For the next topic, we have general symptomatology of mental illness. Psychological symptom is not necessarily evidence of psychiatry. Symptoms are often recognized as abnormal because of their intensity and existence. Nonetheless, even when intense and persistent, a single symptom does not necessarily indicate sickness. It is the characteristic grouping of symptoms into syndrome that is very, very important. So one cannot put up an abnormal behavior and you feel that, oh, this person is actually suffering from mental illness. You must give an observation and observe to know that, yes, this is just a mere something, or maybe it can be suffering from another disease. So you don't just conclude that, oh, this is mental case. So the following has been identified as the signs and also symptoms of mental disorder. Number one, we have disorders of perception. Perception is a personal interpretation of observation and could be described in a wide sense to denote imagery, which is described within the mind, within the feeling of reality. It could also vary in intensity and also quality. We also have another symptoms, which is called illusion. These are misinterpretation of external stimuli, most likely to occur when the general level of sensory stimulation is reduced. It is likely to occur when the level of consciousness is reduced. Example, in an acute brain syndrome, a common illusion is to misperceive that a shadow is taken to be a man. It occurs more often when there is a strong affective state. Example, a person who is confused in a dark lane is more likely to misperceive that he or she saw a man in the dark staircase. And that will take us to another symptoms, which has to do with hallucination. This is also a perception without stimulus. Mental images arise spontaneously within the brain and are projected to the outside as thoughts real. The commonest type of hallucinations are, number one, we have visual, seeing things that others are not actually seeing. Tactical, feeling things crawling on the skin. You see things crawling on the skin. Gustatory, taste. They may claim that their food is being poisoned. Olfactory, smell. Some patients keep away from fellow human beings in the mistaken belief that their terrible smells results in others avoiding them. You have auditory, sound, hearing what others aren't hearing. That is under hallucination. So we also have disorders of thought. This usually recognizes from patient speech or writing and can also be inferred from action of the patient. This term can be used in a wide sense to denote three separate groups of phenomena. Number one, we have particular kind of abnormal thoughts. Example, in delusion, which could be persecutory or grandeur or poverty, always accusing people of harming them, doing things to them. Number two, abnormality of amount and the speed of thought. Example, very fast speech, flight of ideas as seen in manic. Thoughts preserve leading to incoherent. Thoughts block, mental processes are split and fragmented, with a result that thoughts suddenly stops and the mind goes blank. I think that one is simple enough for you to understand. You can jam things from middle to the end, from end to the middle. You may not actually understand what they are actually saying at that time. Number 3, we have abnormal belief about the possession of thoughts. Example, thought broadcast, thought incision. As they are talking, some other thought will come in and they are equally confused to say whatever it is straight for one to understand them. We also have formal thought disorder, linking of thoughts together. Formal thought disorder, linking of thought together. A thought that is not supposed to be in your conversation, just bring it. Example, losing of association resulting in chess can move type of thinking, so that although the patients appear at one time to talk sense and the other end of the interview, the therapist may be confused about what has actually been said. So it has simplified the whole meaning for you to know about formal thought disorder, linking of thoughts together. So also have here disorders of emotion. The word mood and affect are used interchangeably to denote emotional states. Authors recommend that affect could be used for thoughts for short term and mood for sustained period. Affect may be abnormal in 3 ways. Number 1, its nature may be altered. Example, agitation, seen in extreme anxiety, and motor activities is involved. The patient paces the floor continuously. Number 2, depression, as seen in patients, air of gloom and despondence, although smiling, depression is common. Thing might be serious, that she should have been very serious with it, but will be smiling. Especially maybe somebody have come to tell her that your mother is dead. A serious something like that will be smiling. So that's the meaning of being gloom and despondence, although smiling, and therefore depression is also common. So you have fluctuation of mood, maybe extreme form of total loss of emotion, but when the emotion is reduced rather than lost, it is described as blunted or flattening, which affect is said to be labra, when emotion changes in a rapid, abstract, and excessive way. This could also be a continuity of affect. Example, patients laughing when he is told that his beloved mother is to die. So that is it. You all know that. And that will take us to another disorder, which is disorder of memory. Memory is made up of learning, which requires the patient's attention, retention, recall, and recognition. So memory may be affected at any or all of these stages. Retention is impaired in a Kwashiorkor syndrome. The patient cannot retain recent happening, even though he may recall long past events clearly. That is the Kwashiorkor syndrome. So he's trying to describe what Kwashiorkor syndrome is. Patient cannot retain recent happening, even though he may recall long past events clearly. He is not able to retain 6 digits forward and 4 backward. That is an example there, maybe 791368. You cannot do it. That is it. So in recall of the past memory may be affected by strong emotion. hysterical amnesia, or loss of memory. Fuji may also occur in overwhelming anxiety. Deja vu, claiming knowledge of something he or she has no knowledge. Jem vu, opposite of déjà vu. This is also a French expression. Yes, even in an ordinary people, there are people who always display that. They don't know a particular place, but they will stay in Calabar or anywhere they are to describe that particular place they are talking about. So we also have here another disorder which has to do with disorders of consciousness. Under consciousness, we have coma. Patient might go into coma, which can be described as stupor. Common cataphrenic schizophrenia. The next one we have confusion. The patient might go into confusion, which has to do with, sometimes it is delirium, which is acute confusional state. We also have clouding of consciousness. Patient might be having clouding of consciousness, maybe having thought block. Disorientation, that is inability to locate himself in one's environment as to a person, place, thing, or time. So people might even say, oh, this person have dementia. So the next one, the last one, we have lack of insight. Patient does not regard himself as healed. He doesn't have an insight of whatever he's suffering from. Also have here as disorders of concentration and attention. The patient is unable to do what we call serial 7. That is subtracting 7 serially from 100. Example, 100 minus 7. That will give you 93. Then minus 7 will also give you 86. These are the tests you can carry on a mentally healed patient to actually know if he can concentrate, if he has concentration, and also attention. The next order here we have disorders of judgment. Judgment is the ability to perceive and distinguish between relationship or alternative with the capacity to make reasonable decisions. The patient may invest universally. Patient gives out his money away or changes his will. Change in living habits. May divorce also his wife or husband. Will start behaving somehow. There is nothing, will start fighting. There is nothing, will start talking unnecessarily. So these are under disorders of judgment. We also talk about appearance and also behavior. Facial appearance matters a lot. Neatness, uncleanness, speed, movement, tone of speech, attitude towards others are quickly noticed. This is what you will notice as a student of psychiatry who wants to also know what he's doing. A manic patient is overactive, over-talkativeness, impatient, restlessness, aggressive, and sometimes threatening to kill. He dresses in much colors. There may be strange gesture, negativism and mutism, talking to self, and there may be facetious smile. You just taste, he's talking to himself, you see him smiling. That is it. So in psychiatry, we also have other methods, which I may want you to look into. You have observations, recording, and reporting. You have been doing that, and I want you to do that. That is going to be an assignment to you. What are the observations when you go to psychiatric hospital? What are those things you might want to record? What are those things you might want to report as far as a patient is concerned? Because in psychiatric hospital, we cannot do without observation, because you might be in the ward and the patient will start performing something else, which you may not understand. Or even if you don't understand, it might put you into trouble. So observation matters a lot and reporting. So here, I want you to define what observation is and also what are the bases for observation when you get to psychiatric hospital. What are the values of observation? How do you value observation? The basic principle of observation. What are the principles of observation when you carry it out? So that is the assignment for today. And also, another one that I will add to you, what are the opportunities for you to observe during a patient who is in the ward, a mental health patient? Opportunities for observation. What are the opportunities that you want to look into when it comes to taking care of a mentally ill patient? These are the things that you are going to look into. You have misconception and stigmatization in psychiatry. When you get your book, you have the book in bookshop, you look into it and you see all the stigmatization concerning mentally ill patients. Even the people working there, they are being stigmatized. So we have effects of stigmatization, we have family implication, we have psychiatric hospital, family implication. Everything is written out here for you to know. So I may not treat that also. So going further, what are those things that we use in our society to remove stigmatization in one society when it comes to mental illness? So I've given you points here up to 16 that you should read them up. Removal of stigmatization in one society. What are those things that we are to do? And that will take us to the next lesson, which is the changing concepts of mental illness. We have different people in different areas. We have physicians, we have psychologists who have come up with the treatment of what individuals should use in treating mental illness. Changing concepts of mental illness ranges from pre-modern period of the theories about causation of mental illness, causations and factors in mental illness, and the theories and the treatment method have been used because of the belief about mental illness till date. We have pre-historical and throughout history, including present pre-literate society, and some religion, cultural group also believe that mental illness was caused by supernatural and magical forces, evil spirits, devils, gods, and ancestors are what has happened. We also have different people here who have, in the golden age, they have their belief concerning mental illness. It was believed that mental illness was as a result of punishment for individual offending gods. We have example as epilepsy was believed to be a divine. Victims were granted priesthood. So when you have epilepsy, whatever you do for you to go and work in God's vineyard, and based on that you'll be healed. Based on the golden age belief, we have also method here. Method of treatment was by walking and sleeping in a group of people in temples dedicated to the gods of healing and medicine. We also have priests with medical advice from oracle. We believe that when you go to the oracle, you are being advised on what to do. Our great man here, another man here, who believes all. We have Hippocrates, where he started 460 to 377 BC. The father of medicine, he believed that mental illness was caused by body events. Example, brain disease, natural phenomena cause illness. He denied divine causes. He believed in body harmonious basis for personality. His first attempt to classify mental illness. In his treatment, he emphasized doctor-patient relationship, used warm human approach, had concern for had concern physical comfort. We also have others like Plato, who is also a philosopher. He had organismic view about the cause of mental illness. He believed that mental illness was caused by conflict between emotions and reasons. He also believed that behavior was a conduct of total psychology. He utilized reason and teaching to promote good life and happiness as a method of treatment. We also have other physicians, other philosophers, who is no other person than, you have Plato here, a philosopher. You have Aristotle, he has his view too. We have ancient Roman, also we have their views, what they thought about mental illness. You have Celsus, you have Galen, you have early Christianity, Middle Ages. These are all changing concept of mental illness. So I will allow you to go and read up your textbook, go to the bookshop, get your textbook and see there are almost 40 philosophers and a physician who has laid their how mental illness should be treated. So go there, get the textbook and read it on your own. You will enjoy it most. So going further, we will talk about the causes of mental illness. The main cause of mental illness is unknown, but there are two main factors that can expose an individual into developing mental illness. These are, number one, predisposing factor. These are inherent factors that can lead one into having mental illness. An individual possessing the predisposing factor needs 40% of the precipitating factor to be mentally unstable. Predisposing factors are hereditary. The individual inherits this trait from the gene of parents and grandparents. Constitutional factor. This is found in an individual with a certain physical belt, example, Sir John, or the astigmatic belt, picnic personality. Number two, under precipitating factor. These are factors that can trigger up mental illness due to existing predisposing factors. This can be divided into two. We have physical and psychological. Under physical, we have trauma, road traffic accident as a result of bad road or reckless driving. The rate of accident is high, and when this happens, they leave a traumatic scar causing post-traumatic mental illness. The next one we have infection. This is found in the third stage of syphilis, tertiary stage, and also in cases of cerebral malaria, which affect the brain as well as AIDS, septicemia. We also have circulatory disturbance, where we have lack of oxygen and blood supply, leading to hypoxia to the brain, resulting in malnourishment or degeneration of the brain cells, leading to mental illness. Endocrine factor. When there is a defect on the endocrine system, example, we have pancreas, we have hormones, high level of aldosterone, which destroy the function of the brain. Growth hormone spongolism occur. Nutritional factors, that's the next factor. Malnourishment of the body affects the brain cells. Thus, diminishes the development of brain cells because they are not properly nourished, leading to the development of mental illness. Example, we have dementia. This dementia might come very early and late. We have chemical poisoning under physical. This is one of the causes of mental health. An example, there are certain mushrooms that you may not eat, and when you eat it and if you have that trait of madness, it will affect you. You have carbon dioxide from also bush burning. So most of you that want to use generator inside house, you have to be careful and know that it is not good for human consumption. Number 7, we have intoxicants. Example, we have alcohol, which affect the brain among drunks and smokers. Under psychological factors, I have said it that it is physical and psychological. So under psychological, this includes socioeconomic factors. Example, we have unemployment, non-payment of salary, low income earners. Also have here domestic problem. These are problems at home where couples are frustrated in life. Example, neglect lead to poor interpersonal relationship between parents and children, thus causing disharmony at home. Also have environmental factor, poor sanitary condition. Also have here emotional factor, loss of loved ones, maybe property, cases of armed robbery, and abandonment of children in early childhood. That will also affect the brain or affect individual that has trait of madness leading to mental illness. Going down to, well, you need to classify mental disorders. So under the classification of mental illness is based on the following reasons. Number 1, etiology of the disorder. Number 2, we have clinical manifestation. Number 3, we have severity of the symptoms. Based on this, mental illness are grouped into 4 classes. Number 1, we have mental illness. We have mental retardation. We have mental personality disorders, and also psychosomatic disorders. Here with this diagram, it will also show you and give you a very clearer view of what you can understand about the classification. It is already classified here, and with this figure, you'll be able to understand it. Under mental illness, we have here major psychosis, and we also have minor psychosis. From major psychosis, we have organic psychosis and functional psychosis. So under mental retardation, what we have here, we have mild, moderate, severe, and pronoun. Under personality disorder, we have psychopathy, sociopathy, sexual deviation, psychoactive substances abuse. These are under personality disorders. And then we go on to psychosomatic disorder, which under that we have asthma, peptic ulcer, and also hypertension. So by the time you're able to describe them the way I have talked about it, although the notes are inside your textbook, you can actually understand them very well without anything. So that will lead us to treatment. How do we go about the treatment of mental illness? Here under the treatment we have nursing. Under nursing we have physical care, emotional care, psychological care, spiritual care. Under drugs we have clopramazine, Melary, and then haloperidol, stelazine, clozapine, and also the rest that will take charge of it. So we also have here an important one. We have electroconvulsive therapy, especially with the patient who is so depressive and also manic. It is also being used. If you are too active, they will use it so that you become normal, you become less active. If you are too depressed, they will use it on you so that you become elated, very small. So it has 2 functions. So under rehabilitation, what do they do is psychiatry. We have here occupational therapy. We have intervention of medical worker with regards to rehabilitation, employment, and relative. Yes, this is where you find it, especially those who are recovering very well. they have to put them into occupational therapy so that by the time they have their holiday, which is called the parole, they will be able to function in our society very, very well. And that will bring us to the end of this. Thank you for listening. Love you all.